for the field. But another step what we have undertaken is that we have started the fellowship program in neonatology by IAP. This has increased the patient care. We have 3 fellows in the department. Once they go to the periphery, definitely they are going to stand for NSUs. And this is the only way, the way we can increase the rush and we can improve the patient care at the peripheral hospitals, as the districts, as well as the medical colleges. So this CME is going to help a lot in this way. So the topics which have been chosen, they're very wide by the organizing team. The topics are the neonatal care. We have the 3 leading causes of the neonatal mortality, that is asphyxia, prematurity, and the sepsis. All the 3 are being dealt here. Asphyxia, if not taken care of, either it leads to the mortality or it leads to the there are permanent problems. We want to have intact survival. Secondly, is the preterm, which has been discussed. Again, this is an emergency, and the pediatrician well versed, he can start the CPAP there at the labor room and can alleviate the problem. And third problem is that is of sepsis. And all these things, I think my pediatrician will be well empowered by these lectures. And intact survival and increases the NMR. This is about the motive. We have reached the NMR of 9.8. JK has the privilege. They have the proud privilege that we are at 9.8. And if you could increase it further, we have to take care of these steps, 3 steps. And fourth is these congenital problems. Of course, one of them is the congenital heart disease, which is being taken care of by my cardiologist, Dr. Radhika. We are doing the echo right at birth. So if the babies are detected, we are starting the process cycling and we are shifting the babies to the higher centers. So this is one of the steps. As far as the PICU is concerned, again, our PICU is overburdened. We have actually, believe me that I got to know around 12 that 7 of the patients are on ventilator, not in PICU, but in the procedure room, that is in the emergency ward. Why? Because we are having number of patients who come these days. From January onward, we were having the patients with the respiratory problems. We are facing the unusual respiratory illnesses from adenoviruses, from influenza. So, number of the patients, I think 60% of the admissions from January onward was from the respiratory problems. And 50% of them, they needed the support. Hypoxia, how to detect the hypoxia? But we are fortunate that we have enough of oxygen in the hospital after the COVID. All the wards are well equipped with the oxygen care section. But how to use them judiciously with oxygen is a drug. This is not a panacea. We have to use it judiciously, which we have devices we have to use. This I think Dr. Reed is going to develop on this because it will give more oxygen. This is causing damage to the baby also. Another topic is shock. Around 30 to 40% of our admissions, the babies they have the shock. Early recognition and our golden hour management, that is the septic shock bundles, and they need to be addressed. If you detect them early before if you detect late patients going into compensated shock, uncompensated shock, and these babies will come. They will give no time. So early detection and the first golden hour management, they are important. The third topic, which is their diabetic acidosis. As we have seen that with the increase in the financial status of the patients, there is obviously going up and up. We do see, I think, quite a rise in a week diabetic acidosis. So if they are not treated in time, they are not treated according to the protocols, these babies can come. The cause of mortality in these patients is the cerebral edema. So how to manage them effectively? This will again be well for this. The speakers from these are three are of our own students, Dr. Modan, Dr. Suji, Dr. Sushi, Dr. Deepak, and two are the guest speakers, Dr. Atul. Dr. Atul, he is from Canada, he is the senior associate professor, and Madam Jayesh is a professor and in charge critical care and PGI. I think all of us are going to be benefited by their experiences, and this is going to help a long way. Not only they will speak, but the work they have been doing in our hospital is commendable. We have saved a baby of 450 grams, kept the baby from for 3 months, and child has intact survival. So this is the work done by the neonatologist. Dr. Suji, I remember two, three patients I remember, one of my patients stayed for around 100 days, have multiple had septicemia, multiple abscesses, had bilateral empyema, had pericardial effusion, and number of places. So these patients survived, all due to the hard work of our young critical care these uh, doctors. Similarly, all of them are working very well. I think today is academic feast, and all of us are going to enjoy it. And thank you very much, and wish you all the best learning.
Thank you, sir. We are all set and ready to commence on the academic session. I would request our chairpersons, Dr. Deepak Kumar, Senior Pediatrician GMC Udhampur, Dr. Neera Singh, ex-consultant ASCOMS, Dr. Ramesh Khajuria, Senior Consultant Pediatrics Jammu, Dr. Pushpinder Sharma, Senior Pediatrician, to kindly come on the stage. Dr. Ramesh Khajuria, Senior Consultant Pediatrics Jammu. Thank you, sir. I request Dr. Raman to kindly felicitate guest of honor, Dr. Shama Bakshi and Dr. J.S. Jasrotia. I'm honored to invite our first speaker, Dr. Deepak Sharma, consultant neonatologist at KD Hospital, Jammu, on stage to speak on the topic neonatal birth asphyxia and its management.
Giving the opportunity to take on this important topic. So coming to technical asphyxia, why this topic is important. So because what WHO says is around 29% of the neonatal deaths are because of asphyxia. And it is not only mortality, but also the long-term consequences of asphyxia in the form of lactose retardation as well. So today we will be discussing definition what is asphyxia, what is pathophysiology, need to do and how to manage. So what is asphyxia? According to AAP and DFUG, all of the other four criteria should be met to diagnose the case of birth asphyxia. They should be performed metabolic or mixed acidemia. That pH should be less than 7 and depth should be more than 12. A class 4 should be less than 3, and more than 5 minutes. And the features of inherited after the coma, hypotonic, and there will be evidence of multiple organ dysfunction in the so what is the difference of magnetic asphyxia and the nervous system? So there are two cases of neuronal damage in magnetic asphyxia. One is immediate period and asphyxia and failure. During the immediate period, what happens is there is inadequate substrate supply to the neurons. The inadequate supply of substrate to there is decreased ATP production, and there is less of ATP. Sodium calcium form will not work properly. So there is influx of sodium into the cell. Once there is influx of sodium, it leads to iron water influx, which leads to cell swelling and cell lysis. This is the primary insult in the immediate period. So this is the period immediately after hypoxic insult. This is a cancer who side as after. Most of the neuronal damage doesn't happen during this period. Now the primary insult is causing most of the neuronal damage. Most of the neuronal damage after the primary insult is over. So the importance of period between the primary insult and the incoming secondary energy failure. Using this period, we can intervene so that the neuronal damage can be minimized. So you have seen both the primary that certain activity happens in the primary energy failure. Now, most secondary energy failure goes that during the coming period, you had what happens once there is cell lysis. Intercellular glutamate levels are very high, almost 10,000 times highest than the acceptable level. Once cell lysis, after that glutamate is released to extracellular stage. It goes like that. This is the advanced. So this is the advanced, this is the dendrite, and this is the synapse. So there is increase the glutamate, and this glutamate is taken by active. Secondly, and there is active uptake of glutamate into the ascocyte, it is ATP synapse. Since there are more ATP, so glutamate is not taken into the ascocyte. The level of glutamate is in the increasing. This glutamate by acting to NMDA receptors and KMDA receptor, it causes increase in the calcium level. So first culprit was the lack of ATP. Second culprit is glutamate. Glutamate causes increase in the calcium level. So calcium is the third culprit which causes neuronal damage. This calcium causes activation of certain enzymes and causes generation of free radicals. So once there is less of ATP, there is increase in calcium. This calcium causes activation of cytokine proteases, leads to cytokine disruption. Secondly, this calcium activates certain enzymes which lead to generation of free radicals. So lack of ATP, glutamate, generation of free radicals, and ultimately leads to inflammation. These are the steps which lead to damage neuronal injury. So what are the factors responsible? Energy depletion, anxiety, amino acids, calcium, and free radicals on this inflammation. So why I am emphasizing on this? Because all the interventions they will be based on these mechanisms. So what are the steps in management of magnetic asphyxia? The most important step definitely is prevention, but not in our control, so we will not be discussing much about it. Next is the recognition of asphyxia, its severity, and timely recognition of complications. So first, prevention. Prevention by identification of high-risk pregnancies, electronic fetal monitoring during labor, and timely intervention. Next is recognition. So recognition, per definition, we should have blood gas. Blood gas within 1 hour is required regarding or delivery room events, but the last for serious neurological examination is standardized scoring system to define patterns of security and capability will be discussing this. And investigation has been identified severity to manage and prognosticate. So So first, these are the normal values, cycle part that pH and that just value is 71. Average, the average pH is around 7.2 to 7.34. But pH is less than 7 and there is existing more than 12. This is one of the criteria to define a asphyxia. We need to regard all the rooms, resuscitation events. One of the most important things I emphasize is the residents and the resident should know what are the cutoffs at different time periods. What should be circulation? At 1 minute, like 60 to 65%, 2 minutes, 65 to 70%, so that we are not unsuccessfully giving oxygen to baby. Because oxygen causes free radical negativity. Then next is serial neurological examination. We have to do to evaluate severity. Like this is the question of coding system. Next is investigation. Like blood investigation, imaging and electrophysiological studies. The goal of investigation is to identify severity, nature, and prognosis. Blood investigation, but as I already told, and the evaluation for blood care after dysfunction. So coming to imaging. The best modality of imaging is MRI, and it should be done between 4 to 7 days of injury. And ideally, decision making imaging should be done. So, this is one of the there are different types of injuries which we will see, asphyxia. So this is basic idea. See, this is helpless and this is permanent. They are usually involved in severe asphyxia. This is definitely wrong parasitical and it is open many of times other features of like this is an other male. The posterior ring of the kernel that there is asphyxia by the process is there. So it's an upper and one so there is asphyxia. The posterior ring of the kernel that is not hyperintensive, that is hypointensive. And MRI spectroscopy can help in prognostication also. The levels of anesthetic parted in and anesthetic parted like they can help in prognostication. Can help in management. Other things which are required for management of babies is electrophysiological studies. Why this is quite very important to identify fever activity. Many of the time there is an ongoing electrophysiological activity, but clinical there are no fevers. To identify these activities, we need EEG. They also help in management with anti-convulsive therapy and to prognosticate neurological outcomes. EEG or AEG is normally the initial period or there is normalization within 7 days. So prognosis of those babies is very good. So it can help in prognostication also. This is AEG, but this is there are different patterns on AEG. This is continuous normal voltage. These both are most of the times normally eliminated. So if this pattern is there, we know this baby is not having severe asphyxia and baby is not going to have severe complications and fever. The remaining reverse suppression pattern, low voltage pattern of that day, this signifies that baby is going to have may have severe complications in coming years. The third step in management is stabilization of respiratory, cardiovascular, and metabolic physiology. No, many times what we feel, we have read in many times the therapeutic hypothermia is there to improve outcome of babies. So what they can do is they keep baby get a hypothermia. There is difference between hypothermia, therapeutic hypothermia, and non-therapeutic hypothermia. Why therapeutic hypothermia we give because at certain temperature, once the body temperature goes below particular temperature, the metabolic rate is lowest. So to decrease that metabolic rate, we give therapeutic hypothermia. But once we are giving non-therapeutic hypothermia, what body will do? Body will try to save body temperature. So it will basal metabolic rate will increase. So that is going to harm. So you don't have to give non-diabetic hypothermia, you have to keep taking asphyxia also, you have to keep at normal temperature at diabetic hypothermia. But don't be non-diabetic hypothermia, that is going to worsen the condition. Definitely, hypothermia you have to avoid, but non-diabetic hypothermia also you need to avoid. Second, adequacy of oxygenation and ventilation. So these days you need to maintain oxygen saturation between 91 to 95 or pH between 50 to 80. If there is hypoxia will lead to acidosis, leading to capacity ventilation, and it leads to aerobic metabolism, which is important atrophy defect. So you will have to avoid hypoxia. Most of the time, you don't think hypoxia is going to cause problem. Babies are maintaining saturation 97, 98, 99. So you have to avoid that. So hyperoxia is also going to cause damage. It leads to cerebral constriction, and one of the most important things leads to free radicals. So hyperoxia will lead to free radical generation. So ideally we have to maintain saturation between 91 to 95. And I will just this is the check that outside so statement room here 100% oxygen. I found that there is a resuscitating room here compared to 100% oxygen is almost 30% reduction in mortality in the first week and almost 37% reduction in mortality during the first week. So avoid hypoxia. Currently we are maintaining a pressure of circulation. What happens is normally what happens during in a particular pressure range, the cerebral oxygen is maintained. Once pressure goes beyond this, the blood flow to the brain increases, and once pressure goes beyond this point, the blood oxygen to the brain decreases. However, during pressure acid circulation, there is no as the blood pressure is increasing, as the blood flow is increasing, and when the pressure is decreasing, as the blood flow is decreasing, and factors can lead to this passive pressure circulation. As one of another thing, many times patients ask in normal baby, once we gain for CST, we see that saturation should be more than 95. But once baby is on ventilator, why we are telling keep it between 91 to 95. Once baby is on normal room air, PaO2 can't go beyond 100. PaO2 will always be less than 100. But once we are giving oxygen, if lungs are normal, for each increasing 1% increase in area, PaO2 will increase PaO2 by 7. So if we are giving 100% of PaO2 and lungs are normal, PaO2 can go up to 600 also. But saturation will remain between 95 to 100. So once saturation is beyond 95, we have to know how much is PaO2. In normal baby, once baby is on room air, whatever saturation, PaO2 is not going to be beyond 100. But once baby is on some kind of respiratory support, once we are giving additional oxygen, the PaO2 can be up to 600 also. So this is the partial pressure of oxygen which leads to the area of oxygen to tissue, that is detrimental. Not the saturation. You can maintain saturation between 90 to 95, 91 to 95 whenever, but there is an annual kind of respiratory support, and from we are getting additional oxygen. Second point, maintain CO2 between 30 to 50, but this is sitting maybe. Normal 35 to 45 mmHg. If there is hypercapnia, means PaCO2 is more than 50, which leads to acidosis, paralysis, acid circulation, and cerebral vasodilation, leading to intracranial hemorrhage. Hypocardia, it leads to cerebral vasoconstriction, and this dangerous effects of hypocardia, they increase if there is hyperoxia simultaneously. So you have to avoid hypoxia, you have to avoid hypoxia, you have to avoid hypocardia, you have to avoid hypercardia. Then you have to maintain adequate oxygen. The goal for term may be to maintain MAP more than 40, but systolic keeping less than 45% in asphyxia. If there is hypertension, it will worsen ischemic injury, and if there is hypertension, it can lead to hemorrhagic complication. Next, blood sugar. maintain between 50 to 150. Because there is hypoglycemia, there is hypoglycemia, it can worsen cerebral lactic acidosis and hyperammonia effect, which may provoke hemorrhagic complications. The next step in management is control of seizures. Seizures by different mechanisms can lead to brain injury. Already in associated if there are repeated seizures, there will increase brain injury. So all clinical and electrographic seizures should be treated. The question arises, which is the first line medication? Which first line medication we have to give? Phenobarbital, letrozole, or phenytoin to treat seizures. So we have to depend on evidence. WHO recommends phenobarbital as the first line therapy for neonatal seizures. So what is evidence for this? There is a recent meta-analysis comparing efficacy of anti-epileptic drugs for neonatal seizures. They have compared phenobarbital, lorazepam, phenytoin, midazolam, clonazepam, diclofenac, and levetiracetam for neonatal seizures. What they have shown is phenobarbital was better than levetiracetam and phenytoin as per clinical. So one more study that reported this is also a recent study, levetiracetam versus phenobarbital for neonatal seizures. Why I have used these studies? There are many studies appearing different anti-epileptic drugs. But this study, the primary outcome measure was complete seizure freedom for 24 hours assessed by independent review of CME. Most of the studies, they have what they have done is they have seen clinical seizures, but many times there are subclinical seizures. So we have to see EEG-based seizures. In this study, they have assessed many parameters of EEG to neurologists, and what they have found, the primary outcome of 24-hour seizure free, it is almost 80% with phenobarbital and only 28% with levetiracetam. So according to current evidence, definitely phenobarbital remains the first choice for neonatal seizure. So after recognition, stabilization, control of seizures, next is commencement of potential neuroprotective intervention. The concept of neuroprotective intervention is based on drug concept. This is the initial insult, the primary energy failure. This is the initial ischemic core, the tissue brain tissue which is trying to rise. But around it, there is a penumbra. It is a salvageable brain tissue. If we take proper intervention during before secondary energy failure, so we can keep it like this. We can prevent this whole area going into this necrotic area. So the with primary energy failure and secondary energy failure. Between this period, primary energy failure going into secondary energy failure, this is the time period where we have therapeutic window where we can do neuroprotective intervention. So this before we have to start neuroprotective intervention through PICA. So we are discussing what is neuroprotective intervention. Most studies therapeutic hypotonia. So this therapeutic hypotonia works. Decreasing this metabolic state so that more of proteins are available for neural tissue. It decreases accumulation of extracellular glutamate. So we discussed what are different reasons for neural damage on glutamate. So it decreases extracellular glutamate. Next, it decreases generation of reactive oxygen and nitrogen species and it inhibits oxidation. So almost all the steps which are responsible for neuronal damage, secondary neuronal damage, are to activate the therapeutic hypotonia. At least it decreases those mechanisms. So which neonates are eligible for therapeutic hypotonia? So as already discussed, time period should be before 6 hours. If baby is coming within 6 hours, then only we can start. Gestation age of baby should be more than 36 without complete of don't have much of evidence. And there should be evidence of asphyxia and moderate to severe encephalopathy clinical examination. There are different methods of therapeutic hypotonia. One is selective head pulling, where only head is pulled and whole body pulling. These are the different devices used. So what is evidence of therapeutic hypotonia? There is a Kaplan review in 2013 based on 11 RCTs. The results of this meta-analysis was therapeutic hypothermia decrease combined outcome. Whenever we are seeing some major thing, we have to see that's not neurological disability because we want intact survival. So the therapeutic hypothermia decrease that's a major neurological disability at 18 months of age. Therefore, we need to treat for 7. Means you need to give 7 babies to prevent this outcome in 1 baby. So this is the first part. In selective head cooling, this is the selective head cooling. There are almost 23% reduction. This diamond is not touching the line of no head. So definitely there was 23% reduction in incidence of primary outcome. And for whole body cooling, almost 25%. Both selective head cooling and whole body cooling have been preventing neurodevelopmental impairment. However, almost all of these studies are done in 12 countries. But the evidence in low middle income countries. There was one meta-analysis by Korea. In this meta-analysis, 7 trials were included. There was no statistical significant reduction in neonatal mortality with therapeutic hypothermia in low middle income countries. However, data in other neonatal morbidity and long-term neurological outcomes were insufficient. So based on previous to that meta-analysis, still people were using therapeutic hypothermia in developing countries also. But the biggest controversy on use of therapeutic hypothermia in low middle income countries came out with the Alistair. So this is Alistair conducted in India, Sri Lanka, and Bangladesh. With the primary outcome of death and mortality of severe disability, there was no significant difference in therapeutic hypothermia and low middle income countries. But that the secondary outcome that was higher in hypothermia group. 42% in those babies who are cold compared to placebo. That is who are not cold. So after this, the that of having said neonatal and of India clearly position statement. But they say what are their points? They say health facilities supporting to offer hypothermia must have high quality neonatal intensive care facilities and practices in addition prior to embarking on therapeutic hypothermia. The facilities must have access to bedside EMG, CT, MRI, and EEG. The facility must have an most important thing. Nurses trained in neonatal advanced care nurse to patient ratio 1:1 or 1:2. One nurse for one patient or one child for 15 patients. And then it is to be capable of following the unit of therapeutic hypothermia for at least 18 months. So these are the possible manifestations of therapeutic hypothermia. Take some message on therapeutic hypothermia. We need very good analysis to start therapeutic hypothermia. All management protocols should be placed. Neurodevelopmental impairment due to other hypogenic causes like nosocomial substance and ROP should not be a big problem there. EEG facility should be available. Nurse to patient ratio should be at least 1:2 for level 3 patient. Low sepsis rate in MICU because therapeutic hypothermia patients are prone to infection. And facility for regular neurodevelopmental follow-up should be available. Other neuroprotective intervention, the second most studied erythropoietin. What erythropoietin does is it decreases apoptosis, it decreases free radical injury, it decreases inflammation, it decreases ultimate oxygen, almost all things. And long-term effect, it improves erythropoiesis, angiotensin, and neurotensin. In addition to hypothermia, but all things that we hypothermia in addition, it improves angiotensin, neurotensin. So what is evidence of use of erythropoietin in associated disease? There is series of 9 studies that showed reduction in death and disability. They could see the better long-term neurodevelopmental outcomes, reduction in further, again, recently a trial was published, that is trial of erythropoietin for hypoxia and so big trial conducted in 16 and 13 years. So erythropoietin was given chosen per kg versus saline. The primary outcome was death and neurodevelopmental impairment. But they have shown me all of the outcomes. They are definitely line of was no better than placebo. other things.
उस वाला काम हो गया यार उसका नाम है जो यार वो नहीं होता
That's not promising, but there is other arrangement. So I will like to summarize Please to be started within 6 hours. Both of them are going to be AED facility, both of them are doing that. And I was of certificate who has their continuity conclusion. I so waiting affecting us being out. Other evidences and conclusion was that which are speaking of this mistake. Why was the court she is going to I am not going to prepare I status school board be given with as we say we are having hypertension. School borders may be functioning efficiently. If associated with hypertension, we have to see what is the cause. Only if associated externally identified over then only you need to give otherwise ideally we have to avoid because hypotension is not because of hypovolemia. There are other events that are causing hypotension. Second, hypoparathyroidism if it is at the person resistance sharp then to make like hypotension because of we can have inappropriate practical system and responsibility. Acute kidney injury, like any acute kidney injury, you have to manage it. Only thing is respiratory to like kidney cases of what was the rationalization and adenosine and reversal of adenosine immediately the system of out of API guidelines. But impact on fertility, but impact on chronic kidney, but impact on renal state, but impact on because these are the hard outcomes which we need to. There is some like that you can't recommend right at present time. The most important slide after all the discussion, which neuroprotective testing will be advocates on your standard. Doing basic slide. Still got that and at time of delivery. Follow and at least not as important than a better neurodevelopmental outcome. So it is not at least these are the basic that we need to identify. Even if you are starting and maybe is going into success, that is only probably is information one of the damage. If you don't take care of maybe rating 100 and
you have questions from the audience?
Thank Thank you so much, sir, for taking out your precious time to share your valuable knowledge and experience with us. Over to the chairperson.
There is more overlap to take calcium supplementation. There is no overlap to if there is hypocalcemia, then you need to take. You have to check on serum calcium levels. If they are hypocalcemia, then that you need to supplement calcium. Yeah, maybe after 3 times basis, if you are getting 3 to 10, no need to supplement the initial immediate period. But because most of the calcium transport from mobile to baby happens within the 5 that period is lost. So you need to supplement calcium, not for hypotension or hypocalcemia, but to tension level. You need to supplement this calcium and transport because they can retain enough of calcium and transport.
Thank you. Just one question to the most common respected audience. Babies delivered in Patrick Hospital, the area of babies. So what precautionary category should take that baby should take? Other aspects of what is and between the transportation in various systems, we have kind of the transport.
Already we have spoken regarding that because that is the most important thing. So when transport, you need to speak to the transport team. When they are coming, which kind of transport they are going to do. Secondly, before transport, sugar should be maintained. Then hypothermia or hyperthermia, you have to avoid using transport. Blood sugar, you have to maintain using transport. These are the movements stabilization of dysphonic physiology. Whatever aspect, oxygenation, proper oxygenation, you have to maintain. It is not like giving oxygen to maintain 100%. But you will see, they will give you oxygen and they will transport it to saturation 100%. So that should be avoided. All those things which are causing urinary damage, hypoxia, hyperglycemia, all those things have to be avoided unless especially hypothermia.
We have to manage there and that. Then for the as I see established as the ICU so we need to manage those issues there and there. And with the help of hub, that is in our hospital, hub and spoke model, I think that's the ideal model. As a transport is concerned, I think this is not at all working. The 10 or 12 or 30 and the things, of course, the one baby is no maybe hypothermic, maybe hypoglycemic, maybe that the police train the medicine for the adolescents and they can seek help from our center by the center by the model they can talk to all this they're trying to only work it. Transport is not possible.
Final transport will take by Dr. Nanka. Any other question, please?
So on people having you go protector panel. What is your experience? This is all
That was very good recruiting and ICU. There are facilities are available. So in those settings, you can do therapeutic hypothermia. Means we are only using therapeutic hypothermia for newborn babies. It would be criteria for therapeutic hypothermia. We are using therapeutic hypothermia. None of the other neuroprotective strategies we were using. most important stabilization of technique physiology and
Mostly we are in Jammu, anybody has any experience can tell us. The second, what definition you would like to have the medical pediatrician about what definition? These both cannot be met. I think you must not following these both strictly.
but actual people that definition of hypoxia which it can have that he is having hypoxia. First in need of resuscitation. Who prolonged resuscitation was required for baby. Like it, even after 10 years of resuscitation, baby is not having spontaneous respiration, spontaneous breathing support. Then secondly, applause course. Everyone can do applause course. But when the applause course at 5 minutes and what was the applause course at 10 minutes, they can have. Then sentinel events, that is one of the most important criteria. Like if there was adoption, decreased freedom movements. Those are the sentinel events. In presence of sentinel events, if baby is not having spontaneous breathing support, baby is requiring extensive suspension, definitely that puts the criteria of severe asphyxia.
It should be debated on
The best is to manage at that place only. Yeah, that the best thing is because see, therapeutic only thing which you need to do and tertiary care center is therapeutic hypothermia. Okay, the rest of the things, all things can be managed at wrapping up the house because medical colleges are there almost in each district. So all rest of things can be done at that level. Ventilation, ideally we should not send. Ideally we should not send.
Ventilation without ABG. It can be continued and for how long we can continue ventilation without ABG facility.
Okay. That is often the question. ABGs are routinely not required on ventilation. ABGs are not routinely required on ventilation. On ventilation, what you will see in ABG is CO2, PO2, most of times, and pH. Okay, once circulation is improved, it means there is pH is definitely improving. Second is CO2. Indirect marker is saturation. You have to see saturation, not routinely need not to do PO2. Saturation you have to maintain between 91 and 95. Third, PSU, that is the most important thing for which we do ABG. But once baby is on ventilation and there is gentle chest rise. Chest should not be jumping. Once there is gentle chest rise and one ABG, with that gentle chest rise, one ABG shows that PSU level is normal. Then you need not to repeat with same kind of ventilation.
How to get a baseline if you don't have any.
Okay, if you don't have a vertical
The one we have to continue the ventilation. The last 2 months that we had a patient baby who was ventilated for 1.5 days, and finally we have sent the baby to them, and it turned out to be.
Saving the time of the presentation. Thank you.
Respected audience, sorry to interrupt you. I would like to draw your attention to a wrongly parked vehicle. The registration number is HR 59D 3680. Please park it properly, I request you. HR 59D 3680. Thank you.
Thank you, chairpersons. Now I would request our chairpersons to kindly felicitate the speaker. I would also request Dr. Vindhya Gupta to kindly come up on the stage and felicitate our chief chairpersons. Thank you, sir. Now I would like to call honorable chairpersons, Dr. Vikas Mahajan, Associate Professor, Ascom's Hospital, Jammu, Dr. K.R. Sangra, Senior Pediatrician, Jammu, Dr. Neeraj Gupta, Consultant Pediatrician, GMC, Roda, Dr. Rajesh Cole, Consultant Pediatrician, SDH, Hiranagar, to kindly come on the stage. Thank you, sir. I request the chairpersons to please press the buzzer after 25 minutes and 5 minutes after that would be for question and answer. Thank you. I would like to request Dr. Sushil Sharma, Assistant Professor at Ascom Hospital, Jammu, to come up to stage and throw some light on the topic neonatal shock and its management.
Thank you, everyone. Neonatal shock is a major challenge in neonatal life. It's a common pathway for various neonatal illnesses. And it's one of the preventable cause in neonatal life. So, experts neonatal shock carries management. And it's also training unit, and currently he's playing private practice. So I would like Dr. Shukir to start the section, and we have 25 minutes for presentation of 25 minutes.
Thank you, sir, for the kind introduction and a very good afternoon to the audience. So, not wasting much time, I'll outline the objectives of my talk. There are two talks on shock today, so I may run through some of my slides. I will go through the definition of shock, its pathophysiology, clinical features, role of echocardiography, which is very, very important nowadays. And then we'll be discussing some specific neonatal conditions and how to treat them if there is a shock. What's the definition? It's actually it's actually an imbalance between the oxygen demand and oxygen demand. Which leads to tissue psychosis. And the pathophysiology state that the this imbalance is what we call as shock. Usually this often second by but if it gets too long, then what we see is an uncompensated state, which is much more frequent to be requires a number of medicines. So earlier it's picked up the battery is for the patient. There has been a growing realization currently that the way we were managing shock, it may not be the appropriate. So we were limited in our assessment. We were limited in our understanding of the shock. And then this choice of our standard approach for so we knew this is the baby, the condition has a clarity. We need to maintain APF, let us say, 40 millimeters per day in a new country. So they will give it for the start of the add another icon, change that value, and most of the times the unit of the effect would respond and equal. But sometimes it does not address the complexity of the underlying problem, this approach. And in some circumstances, it may cause a new problem. So we'll look at in detail about what can be done in those situations. First of all, no neonates are a very heterogeneous population. We got neonates of 24 weeks gestation, who are very different from what we get at 36 weeks of gestation. So because of that heterogeneity, we cannot give like drugs to all, and I cannot give similar kind of policies. Why? Because the neonatal myocardium has one contractile like CME. It is in a higher basal contractile state and has higher sensitivity to changes in control. And there are other features like greater surface volume, that shows reticulum and reliance on extracellular calcium. Also, what is happening at that point is there is a transition from fetal circulation to neonatal circulation. And during that transition, sometimes the pulmonary pressures may not fall as expected. So what we can see in some cases is persistence of higher pulmonary pressure, which we also call as KPH. And then there is also evidence supporting that these small neonates may be lacking cortisol. So that's also not a role. So we don't really understand different populations of pediatric populations. The management is also different. The specific neonatal conditions and how they impact inflammation in any way. Because they can show myocardium, we can see reduced activity, reduced cardiac output. The vasomotor tone is also immature, which can alter the systemic response. Then we've got a drug which can lead to shunting of blood either from left to right side or right left side, depending on the pressure. Sepsis can affect the vascular resistance of both systemic and pulmonary respiration. Hypoxia, therapeutic hypothermia, PPR, mechanical ventilation, and blood loss. All these impact cardiac output, vascular tone in different ways. How do we assess cardiac output and tissue condition? We all know that blood pressure is equal to 5. And cardiac output in turn is cardiac and stroke volume. We can measure the blood pressure, we can measure the cardiac output, and from there we can derive the systemic component of it and see what it actually is. So there is a lack of sensor definition of hypotension in units. Why? Because blood pressure in units is affected by various demographic factors like birth weight, gestational age, postnatal age, and then there are these coexistent clinical factors also, like whether the mother has received antenatal steroids or not. So whose mother has received may have slightly higher pressure than the one who hasn't. If there is a PDA or not, the level of respiratory support the neonate is getting, and therapeutic hypothermia. So because all these factors they impact the blood pressure, so there is not a sensor definition as of now. But what we are following now is called as BAPM root or the British Association of Perinatal Medicine. They came up with this very simplistic definition that mean blood pressure at birth is almost equal to the gestation age in weeks. So at 28 weeks at birth should have mean blood pressure of 28 millimeter mercury. So we kind of follow this definition, although it's not backed by robust evidence. Perhaps the best way to think of blood pressure in units is to think of two different pressures. One is the evaluation pressure. We just talked about the backbone rule, and then another is the trigger pressure, the pressure on which we actually act. So there may be some units who are very stable, have slightly low blood pressure, but we don't act on that. But then there are another units, the patient feels that needs support. And depending upon those other equally important elements, which are clinical, biochemical, or other objective assessment criteria, we decide that this is the pressure level that we need to maintain, and that pressure level we call as the trigger pressure, which may be slightly different, slightly lesser, or maybe even more than the evaluation. The clinical features, we all know about these, most of these. So there can be alarm, poor feeding, tachycardia, temperature instability. Hypotension is a late finding in neonatal shock. So before the patient lands in hypotension, most of the times since the nurses were caring for the babies, so they should be very well trained to look for these clinical features and inform the consultant as soon as possible, so that a baby with shock is picked up in an incompensated state and acted upon. The late features also include the weak peripheral pulses, low central venous oxygen saturation, acidosis, elevated lactate, etc. So these are the list of conventional parameters which are being used. Capillary rate with time, urine output, heart rate, blood pressure, lactic acidosis, venous saturation, daily oxygen difference. The new parameter and which has revolutionized the management of neonatal blood pressure, neonatal shock is functional echocardiography. So all units are in shock to that functional echocardiography for the management. And then there are global parameters which are under clinical research. Let's have a look at the echocardiography and see how this can help in better management of neonates in shock. So, like we said that generally we start with fluid bonuses. We can assess the fluid and the preload state of the neonate with echocardiography. But it can be affected by changing lung compliance in the neonates and mechanical activation. How can this be done? The assessment of preload or the fluid status. We can look at the left ventricle, the inferior vena cava, and the right side of the heart. The see how much fluid. We can see in this picture. I can go and the view on the echocardiogram and this picture. So we can see the difference. This is volume over yeah, we got volume. Likewise, this is the parasternal complex system, and here the ventricle. The ventricle what is the pulmonary hypertension? Lot of patients who have pulmonary hypertension, which can be measured with the help of echocardiography. What we see in pulmonary hypertension is PRJ. We can assess the shunts, the direction of the flow, the interventional step up, and then there are another criteria which can be used. So the first thing is left ventricle is quite good. It's got a concentric wall, whereas in the second image, the right ventricle is pushing this wall, and the left ventricle is seeing it's got a amount of blood in it. So this flattening of the interventricular septum, because the right ventricle is pushing this interventricular septum towards the left ventricle, gives us an idea that perhaps the pulmonary pressures are very high, and we need to do some other measures like this PRJ. So because the pulmonary pressures are very high, right ventricle output is to the pulmonary tree, but the pressures are very high. What we get is the tricuspid regurgitation. With the help of a dog, we measure this PRJ. We know the pulmonary pressures. That systemic perfusion, like the right ventricular output and the left ventricle output, can also be measured using echocardiogram. Only one line I like to stress on this is that SVC flow is unaffected by fecal shunt. The ventricular output and left ventricular output, because there is a shunt between the two, will be affected, but SVC is not. And it has been discussed as a surrogate for cerebral blood flow. Although there are different reports about association with the long-term neurological development. Then we also need to rule out critical heart disease while managing the neonatal shock, which can be done with echocardiogram, like pulmonary atresia and coarctation of aorta, and also see if they and if it's hemodynamically significant or not. So these are the parameters of a hemodynamically significant. If it is hemodynamically significant, depending on the condition of the patient, we may want to treat it, and generally helps with the management of shock also. Then the next step is to identify the underlying pathophysiology and characterize the shock in distributed, hypovolemic, obstructive, dissociated type. So in distributed shock, what happens is that there is vasodilation, abnormalities within the vascular blood, which could be because of the endotoxins released by sepsis or some other even vasodilators, and there is a lot of vasodilatation. Why we are classifying this shock into these different types? Because the management will be different for each one of them. And the effects of pump, the cardiogenic shock, where the heart is not functioning optimally, so it can happen in disease, arrhythmias, cardiomyopathies, and this one is very important. The post-duct ligation syndrome, which we will be discussing in subsequent slides. There could be inadequate blood volume. A lot of blood is lost during the delivery. It can result in a hypovolemic kind of a shock. No restriction like in pneumothorax, cardiac component, and all respective type of a shock, and inadequate oxygen releasing capacity and severe anemia can cause disassociated type of shock. This is the summary of the echocardiographic release that we see in patients of shock. The top two are the qualitative assessments, whereas the bottom two are the quantitative assessments to measure the cardiac output and other parameters. So now we've gained a lot of information. We've got this information on the demographic variables of the units, where we know the gestational age, the postnatal age, birth weight, gender, etc. We also know the risk factors for sepsis, medical history, pregnancy. And we have done the clinical evaluation, including both the subjective and the objective measures, including the capillary lymphocyte, urine output temperature, respiratory stability, etc. We've got our investigations. We are monitoring the heart rate and saturation, and then the echocardiography. We know the cardiac status of the patient. It's finding the clinician's analysis and intuition, which is influenced by the experience, evidence, and beliefs, as well as opinion of other team members, which in future may be supported by more evidence, more data analysis, and finally a decision is made on what drug to start, how to proceed, how much to give, how long to give. So these are the therapeutic endpoints for the management of shock, which were given by medical college. At the end of 1 hour, we should have CRT of less than 2 seconds. Normal and equal central and peripheral pulses. Warm activities during our course, normal mental status, normal blood pressure, normal glucose molecule. These single blood pressure value. So, volume support is the most commonly used initial treatment because it increases payload and hence cardiac output. Even in the absence of hypovolemia, initially, hypocalcemia are not available. We can give a volume support of 10 to 20 ml per kg over 30 to 60 minutes, which is reasonable and is backed by evidence. Then dopamine and epinephrine. So these are the various drugs that we use in the treatment of shock. These are kind of similarly acting vasopressor inotropes. So they increase both the systemic vascular resistance and myocardial contractility. So what they are going to do is that they are going to increase the cardiac output and also increase the systemic vascular resistance. So they are going to increase the pressure by both the mechanisms. Like we know blood pressure is equal to cardiac output into SPR. So these two drugs are going to go both. Then we have got dobutamine, which is a kind of more, but it has a peripheral vasodilatory action. So from here it's increasing the cardiac output, but because it has a vasodilatory action, the last effect may be a little variable. Generally increases the blood pressure, but because of the vasodilatory action, it may not be as potent as these two in some situations, but used in various situations which we'll be discussing. Then we've got milrinone, also an inodilator. It decreases the peripheral vascular resistance. But what is very, very important is that it also decreases the pulmonary vascular resistance. So very helpful in cases of pulmonary hypertension. Then we've got these vasopressors, nyloprine and vasopressin. And vasopressin again, it causes complete vasoconstriction, but through the V1 receptors, it causes relaxation of the pulmonary vasculature, which we want in cases of pulmonary hypertension. That the pulmonary vasculature should be relaxed, whereas we want our systemic resistance to be high so that we can have reasonable blood pressures. The mechanism of actions of different agents and their drug dosages are given in this table. So dopamine, we have those from 1 to 20 mics per kg. Similarly, dobutamine 5 to 20. These are the receptors on which they act. Like I've said, dopamine, epinephrine, almost similar type of actions. Norepinephrine is a vasopressor. It increases the systemic vascular resistance and it doesn't have any much inotropic effect. So it's not acting on the heart much, but it's acting on the peripheral vasculature to increase the systemic vascular resistance. So we also know that units are sometimes cortisol deficient, their adrenals may not be functioning as well as the older adrenals. Hydrocortisone has. So this is 1 to 2.5 milligram per kg, 0.2.5 milligram per kg, 4 to 6 hourly. Vasopressin increases SPR and decreases the pulmonary vascular resistance. Milrinone again, it is inodilator and increases the contractility and decreases SPR and decreases the PVR as well in cases of pulmonary hypertension. What happens in hypovolemic shock is that our preload is less. So IV fluids are going to help. Cardiogenic shock or cardiac output is less. So we'll need inotropes. And in distributive shock or systemic vascular resistance is less. So there is more role for IV fluids and the pressure agents.
Again, so how do we approach the patient of shock pathologically? If systolic blood pressures are low, but there are normal diastolic blood pressures, like it can happen where in the conditions of low cardiac output. So what they will give them volume followed by inotropic drugs. So here we need to up the low cardiac output. So we need to explain with that if there is no response, we can consider epinephrine because it's again got inotropic effect and through its effect on increasing SCR, you can again raise the BP through that mechanism also. If it's the diastolic pressure which is low, it can be due to low peripheral vascular resistance due to sepsis. Like here we'll again start with volume expander, but because of low peripheral vascular resistance, what we want to do is raise the central vascular resistance. So we'll start with either dopamine, we can consider norepinephrine or vasopressin, which are purely vasopressors. So here we'll not like to go with let us say dopamine, which is acting upon the cardiac output. Here we'll like to start with drugs which are acting upon the peripheral vasculature to raise their resistance and hence increase the blood pressures. Now, if these conditions take so long, what we get is more systolic and diastolic low blood pressures. We initiate treatment with volume and then start epinephrine and consider early targeted innovative echocardiography to see the particular physiology and act accordingly. So I have 3-4 innovative conditions which I will be discussing very fast because of the manner of us. One is that in extremely low birth babies, is it okay to let them have slightly lower blood pressures? The recent evidence, happy page 2, it says that those neonates who did not receive any antihypotensive treatment, as compared to those who did, had bad outcome. So, but there are other trials going on, and we don't know the answer yes or no, but we should try to maintain it as close to the background age as possible. Then there is hypoxia ischemia. My friend Deepak was discussing about this. Pulmonary hypertension is very common in HIV, and it causes exacerbates the degree of circulatory performance. And because the patient is under therapeutic hypothermia many times, it decreases the cardiac output. But because the therapeutic hypothermia is reducing the tissue oxygen demand also, low heart rate and low cardiac output are sometimes appropriate response. But very important is that clinical features of shock such as skin color, CRT, urine output are no more very reliable. So most of these babies, they will require invasive blood pressure monitoring for their treatment. And there is myocardial dysfunction in hypoxia ischemia. So what we'll like to give is, we'll like to support their myocardial function with inotropic drugs like glutamine. If there is pulmonary hypertension, we can start with, if the blood pressures are okay, we can start with milrinone because we know that milrinone itself can cause a little bit of decreased blood pressure because of experimental inotropic reactions. So only blood pressures are fine, we can start it. It will reverse the pulmonary hypertension also. But if the pulmonary pressures are very high, we'll need to put them on inhaled nitric oxide treatment, which is a treatment of choice for pulmonary hypertension. Now, sepsis of OCS volume is needed in sepsis because there is peripheral vasodilation and in lot of third space leaking in sepsis. Whether to start with epinephrine or dopamine is the big question, and it really depends from center to center. But the evidence currently shows that those who are treated with epinephrine had reversal of shock earlier than those who were treated with dopamine in septic patients. But overall mortality was very similar in both the groups. So still a controversial topic. Some centers are initiating with epinephrine, other with dopamine, who are very comfortable with using this drug for ages together now. So still a topic of research, ongoing research. Norepinephrine, because there is a lot of peripheral vasodilation, it is a vasopressor, it will help in the management of these patients. The two more slides, and then we are done.
Ulcer may be very, very difficult to treat if it is hemodynamically significant in some patients. It may require boluses, lot of inotropic drugs. What I was going to talk about is sometimes during the mucus state, a PDA is ligated. What happens when a PDA is ligated is that the left ventricle, which was in now pushing out the blood, was pushing both into the duct as well as into the systemic circulation. Now the duct is suddenly closed, so it is pushing blood against much higher resistance. So there is left ventricular failure which is occurring at that point of time. And so therefore, close peri and post-operative monitoring is mandatory. We can decide to give some peripheral, this peripheral vascular dilating drugs like milrinone, which also supports the heart to its inotropic action. And also, so both these are almost similar in action as far as the their physiology is concerned. And hydrocortisone may be particularly effective in these cases as well. Finally, nitrotizing enterocolitis. We see a number of these patients in our NICUs. So the first line again, because most of the times it's associated with also volume replacement, followed by inotropes. Now, very important to remember is that the catecholamines that we use, their action may be altered due to reduction of perfusion of intestine. So vasopressin is another drug which uses a different receptor to catecholamine, and it may be preferable in these small infants. And because there is a lot of intestinal vascular resistance, increased abdominal pressure, ventilation, so all these reduce preload, we can give them quite a number of fluid boluses as well. And then it was also seen that there is myocardial dysfunction because of the endotoxins that are released. So we can support the myocardium with drugs as well. So it's a combination of fluid therapy, inotropes, and vasopressors, which is often required in cases of necrotizing enterocolitis cases. There is some lack of evidence, but it should not result in inappropriate simplification of treatment in these patients. So low blood pressure, it should trigger evaluation of the infant's status, including a spectrum of physiological parameters, clinical parameters, and objective assessment of the hemodynamic status. And this brings complexity to the bedside management, no doubt. We are not following the simple algorithm, but it should also result in a more individualized approach and should do more good for the patient. Thank you.
If we are fortunate from the audience, we can take 1 hour for the anyone? So it's very clear. Yeah.
Sir, so dopamine has different actions at different doses. If we start it at 1 to 4 mics per kg, then it's a renal and mesenteric dilatation that's happening. If we are giving it at 4 to 10 mics, then it's the inotropic effect that we get. And if we give it beyond 10 mics per kg, we get the vasopressor effect. So it really depends upon the clinical situation that we want to tackle. If we want to support the heart with the inotropic action, we'll start at somewhere between 5 to 10. But if we want the vasopressor action, also we'll go beyond that. So there are different receptors at different places, and some of the receptors are activated at different places.
Yes, no question. Thank you.
Thank you so much, sir. It was a great pleasure to listen to your wise words. Now I request the chairpersons to kindly felicitate Dr. Sushil. Now, I would like to call our esteemed Dr. G.S. Saini to felicitate the chairpersons. Thank you so much, sir. Now, I would like to call our chairpersons, Dr. Sunil Dutt Sharma, Professor and Head of Unit Pediatrics, GMC Jammu, Dr. Kaushal Khajoria, Associate Professor, GMC Jammu, Dr. Virinder Kumar, Professor and HOD, Head of the Department Peds, GMC Kathua, Dr. J.S. Jastrotia, Senior Pediatrician, Kathua. Dr. S.S. Salakia, Senior Pediatrician. A role model for all the youngsters in our community, Dr. Anumodan Gupta, consultant neonatologist, SMGS Jammu. Sir, kindly come on the stage and share your piece of knowledge with us on the topic neonatal respiratory syndrome and its management.
Good evening to all of you. Today's my talk is on respiratory distress in newborns. I'm very thankful to the organizers. They've given me opportunity to talk on this very important topic and also a simpler one than my predecessors. So most of us are already aware of few things about the RDS. So look at this number sheet. Most of us get say or in a midnight or from other centers that some baby is being delivered with kind of a respiratory distress. So this can lead to a lot of nightmares for us and to exclude all other diseases and then confine to simple respiratory distress syndrome is a bit tedious. So this sheet is not for any reading, just to make you aware that history can be like this. You keep on noting and then you have to exclude the disease. So my talk will contain some introduction, some definition, factors about the RDS etiology, examination, investigation, prevention, and then we will proceed to a little bit of a treatment. This is what we have to look. Some baby, a newborn or from a medical center will come to you, you have to identify is it a respiratory distress, and then delineate the etiology, and then you should have a approach to the management. So the most common morbidity regarding condition of the neonate is a respiratory distress. As lesser gestation age, most of us know that early preterm will have more chances of getting a respiratory distress than a more mature term babies. So to have delineate the diagnosis, you need some type of a historical clues, some type of investigations, and then we can proceed how to manage such baby. So we will proceed in a simpler way. First of all, we will know what is the respiratory distress. These three factors who should be there, like tachypnea, rate should be more than 60, retractions, it can be intercostal, it can be subcostal, and noisy respiration. Remember, it is not only grunt. Spider or bees can be there, but it is very rare. But in definition, you must have read only grunt. So these are some points noisy breathing in a newborn. You have to exclude these things. Better. This is very common nowadays. In winter, you will find most of us using a nasal cleaner and writing a nasal blockade. So that statistical and a epidemiological definition is better. And then followed by spider, wheezing, and grunting. All these are physiological responses to a lack of oxygen. So what are the risk factors? You come with a prematurity, you can have a meconium stage not include, you have a cesarean section, you will be getting a lot of PTA, gestation diabetes, leading to a secondary respiratory distress syndrome, maternal colitis, maybe leading sepsis, and again leading to a neonatal respiratory distress. And even prenatal factors you have to exclude. Whenever you are looking for a respiratory distress syndrome, you have to exclude certain things, and a perinatal factors are the prime most important. Most of the things you can learn from that point of view. As we are discussing a respiratory distress, so most of the respiratory causes can be excluded by just looking at the developmental stage. There are 5 phases. Most of us know that starting from an embryonic phase up to vaginal phase, there are some development, and any kind of a developmental defect can lead to certain conditions which you most of us all are aware of them. CDH, CPAM, all these will originate during the period whenever there will be an insult at that particular time. So etiology that we have to deal with what we are dealing with. You are having a respiratory distress, you are having a grunt, you are having a respiratory rate more than 60 per minute, and now you have to delineate. If you have to delineate, you have to delineate for the respiratory disease. You know, we tend to say focus examination, initial focus examination. So you have to delineate either it could be airway, like your pulmonary trachea, your period sequence, which are very common days. Your pulmonary part, RDS, it is a respiratory distress syndrome, meconium respiration, neonatal pneumonia, all which have been highlighted. These are very common. Others are there, but it is very rare to find, and we are lucky to have only 10 or 50 diseases which we have to deal, not like pediatricians, which will number in hundreds of diseases. So, in thoracic part, you have a pneumonia right now, you have just got deformities, or you have to exclude. Then it is important to differentiate it from a cyanotic heart disease. You are dealing with the respiratory part, or you are dealing with a congenital heart disease. So better you know the physiology and you know the aspects you can deal with. And along with that, neuromuscular part, never forget that. You can have a CNS injury or some kind of a chromosomal aberration, like cerebral malformation can be there, and sepsis. Sepsis can present as any damage. You need not to have just a bluish or any kind of a baby ashen gray. Your sepsis should be ruled out in India. Any kind of pathology you are dealing with. So these are the different differential diagnosis of a baby who can present you to be the respiratory distress. We have divided it into term versus pre-term, because whenever you get a call, you will eager to find are we dealing with a preterm baby or a term baby? Are we dealing with a baby who is well inside a mother's womb, or he has got some kind of insult outside a womb? So you have to differentiate with a timeline period less than 6 hours, 6 to 24 hours, and more than 24 hours. It is not that these diseases seen only less than 6 hours, it can overlap. So rather than taking care of a newborn, and in 6 to 24 hours, you can have a meconium who was well in some moment, but then deteriorated in the meanwhile. Then you have the pneumothorax, pulmonary hemorrhages, all the complications you can get while dealing with these babies. And in preterm, the TT and B is replaced by your HMV. And even pneumonias, lung malformations are most common as compared to your term babies. So similarly, congenital pneumonia can be. So these are historical clues. You need not have a big machine, the X-rays and all those things. Just by looking at the demographic variables and the physiological variables of the baby, you see cesarean section with a late preterm or early term baby with some kind of a fetal distress, you can label early PTN. But remember, it is a diagnosis of exclusion. Don't jump any disease so that you have to exclude the other things before labeling it. Neonatal pneumonia, all the risk factors you could have in mothers, and then you will find that baby is deteriorating sometimes. So RDS, a rule, premature baby not maintaining saturation or any kind of a respiratory distress, you can have a baby with RDS and secondary RDS. Pneumonia can lead to secondary RDS, maternal diabetes can lead to secondary RDS, aspiration can lead to secondary RDS. So remember all those. Meconium aspiration easy to diagnose, your meconium state amniotic fluid, then you have a fetal distress, all those quad ABGs, all are in a shackle. So air leaks from sudden deterioration. All of us knows though pneumonia, then you will find out those output. And never ever forget about IEM. As somebody told in the group previous week that they were thinking of a RDS and lack of ABG machine. They sent a baby to a higher center and they found that they were dealing with the IEM. And some historical clues to common respiratory diseases like CDH. You will examine statewide abdomen, your heart sound over the right chest. Similarly, there are so many diseases you can have a good overview, like by respecting all those historical clues. Then important part is examination. It is not that your clues have given you. You have to proceed and then you have to look what kind of baby you are dealing with. Respiratory focus examination. You have to watch for respiratory rate and all those things. Check air and free, latency of nostrils and all those examination. Then go to other system also. You may be dealing with a CDH and looking for those findings, then follow it to liver and spleen, then look for chest, then for the spleen. All those things give you some kind of a clue. So these are the most common scores you are dealing with. During examination, get a quick look, give a Downey score in term babies, even if you give pre-term babies, but more of a reliability is in term baby. This score 500 easy to apprehend over there. Then this Silverman Anderson score, this is mostly for the pre-term babies and have 500 easy to look out. And remember, Silver Anderson score cannot be used when you are using a treatment modality like a CPAP you are given, you are abutting the layers. So your score will come to 10/8. So you can have a less sensitivity and specificity while using this score on a treatment protocol. So some investigations like ABG, radiograph, electrolyte, and some special investigation to rule out your cardiac disease and get these are past digestive respiratory test and respiratory for polymorph. ABG analysis is very important. Basic values, that pH is what kind of a normal value. Then specific X-ray findings. So you examine a baby, PMS score. Now look for a ancillary studies, like just the X-ray. Classical X-ray findings are there. You have a TT and sunburst appearance. You have a neonatal pneumonia with patchy atelectasis there. RDS classical low lung volume with your reticule, then your shadows, air chronogram, ground glass opacity. Mass, you have a areas of patchy atelectasis and PPHN. There are two types of a PPHN, your black lung PPHN, your white lung PPHN. There you have some differentiation. So these are some X-rays. Look at this fissure. This X-ray will look like a heavy low volume, but look, this kind of a fissure. So this can be a severe TBA. Then you have neonatal pneumonia. This is a patch which is being originating over the upper lobe. This is a classical RDS. Your reticulogranular patterns, your air bronchograms, low volume lung, any lung volume, you calculate by looking at X-ray with your AP diameter, and these ribs are less than 6 and more than 9. We say hyperextended or low lung volume in less than 6 or 7, some books may write 7. This is a mass X-ray. Look at the patchy atelectasis, small atelectasis are there. This is PPHN, what I was telling, like a black lung PPHN, looks like a good X-ray. All the lung fields are normal, black. But sometimes if you get such kind of a PPHN who is not maintaining saturation, it is very difficult to treat such babies. Always remember a black lung PPHN. And now turn to audience, what is this? RDS term unit. PGs. बोलो यार कुछ सिर्फ सुनने के लिए isn't it pneumothorax? What is this? Good, excellent. So you have now examined a baby, given a score, have some look at your chest X-ray. Now look at the advanced things you have. If you have a ABGs, if you have good neonatal level 3 NICU, you can look at all these parameters, which are very important if you are dealing with a sick neonate. If having a severe mass, not maintaining saturation on your normal ventilator, may need a high frequency oscillator with a QR. You need to look all these parameters like alveolar arterial oxygen saturation, your A by A ratio, your oxygenation index. It is very important. Always remember, and I used to tell my resident also that always calculate OI or OSI. If you don't have a ABG machine, calculate OI, because this will give how you have to transit from one state to another. That is, if you are using CPAP, you need a mechanical ventilation. If you need a mechanical ventilation, which kind of a mechanical ventilation? Is it your normal unit ventilator is enough to deal with babies, or you have to upgrade it to high frequency oscillator? And if OI is more than 40, you have to look for a ECMO like picture also. So always remember these parameters you should have in your mind. So this is very important. You have done all your basic slides, you have examined and all those things. Always remember you have to differentiate it from cyanotic heart disease. Whenever you have an RDS which is not settling, which is taking some time, and you are thinking that saturations are not even improving after giving a surfactant. So these are some historical things. In pulmonary, you can have a fever before you stay and bleed the military. But in your history, in a congenital heart disease, where maybe previously sibling may be having a CHD, and if one baby gets, chances of getting another sibling is around 6%. So always remember this, your physical examination will be different from your respiratory distress also, and chest radiograph and ABG along with your those tests which will increase a PO2 in response to your oxygen or your ventilation, that is a hyperoxygen. So if we are done with all these things, we can prevent, and important preventive measures which you can prevent respiratory distress in a preterm. All of us know the antenatal steroids. Until date, most of the studies have done for longer period of from 24 to 37 weeks and by election trial. So still, our WHO and guidance say 24 to 34 weeks of a gestation, you have to administer not effect on your respiratory distress syndrome, but also on other parameters like your baby may not get a MEC, may not get a IVH, may not get a longer stay in a hospital. Those you cannot let the patient to room in for more than 5 or 7 days. You have to keep the patient. And treatment part. So we are done with what is respiratory distress, how you have to differentiate, what are the examination findings, what are the historical things, classical X-ray findings. Now we have to focus on the treatment. Treatment will be different for preterm, and treatment will be different from a term baby. So initially, if we are in periphery, oxygen is like our main machine gun. Whatever kind of saturation we get, we will start with an oxygen and we feel, oh yes, we are done with this. Don't need to go to higher center. So there are some things you need to know when to be. When you have a clinical symptoms, mostly is there or presence of respiratory distress. irrespective of a oxygen saturation. And in periphery also we can get a short bilateral response or a oxygen. So supportive treatment remains mainstay in neonatology. Always remember, your big guns will not let a baby to move out of NICU. This is the basics of neonatology. You have to keep a supportive care like temperature, airway, breathing, circulation, avoiding antibiotics and all those things, which will keep your baby alive and also will be out of NICU. So what are the definitive management if I tell ask you about your freedom baby? It is affected. We know it is a replacement of the surfactant. It is a standard of a day for a RDS with a freedom. So many surfactants, you know, there can be mixed lung extract of a bovine lung, then your posse. So if we have to answer that which one is better, it is very difficult. But if you have to compare to most of the studies have done, Foreign alpha is always a better than your any other surfactant because of the less close is curoside. Because the less close and a good response to therapy. Now come, you have given oxygen, you have started maybe on a surfactant with your CPAP or insurance therapy or diesel therapy. We will discuss later. And then we will come to non-invasive ventilation. Baby is not suckling, feet of baby, RDS, oxygen we have used. We have given a surfactant, but you need a CPAP for that, and CPAP is a gold standard always. Nowadays, every unit is having a one CPAP fan. Who says I can treat everything with a CPAP, but it is not like that. Ventilation may be required in some baby, but still a CPAP should be started. CPAP is a good armamentarium for the treatment of a neonatal RD. The rule of CPAP is simple. If you know nothing about CPAP, the rule of 5 is there. Start with your 5 centimeter of a water of a pressure, your effort of a 50, and your flow of a 55. So this is just the rule. And when you will say rule of 7, your 70 of a FI2, your 7 centimeter of a flow, and your 7 centimeter of a water. So your CPAP failed. Then we will move to CPAP also failed. NIPPV. So non-invasive pressure ventilation. We are not putting a tube into baby because tube is a dangerous thing. Whenever you have put a tube, keep in mind you have to remove as soon as possible. Keep in mind what is the right time you need to put that tube away from that baby. So NIPP various guidelines have given various kind of things, but where just a simple rule, if you are giving a baby of a CPAP and CPAP has failed, start with around the 14 centimeter of your pressure PIP. Then you can move with the increment of a 2 centimeter and with the increment of a FI2. Now it has also failed. Then we will come to mechanical ventilation. There are some indication and some good notes, but we are here not to discuss all these things. We will discuss what happened in RDs. There is a surfactant deficiency, there is a low FRC, there is a low compliance. So FRC can be improved by using a surfactant. So your compliance can be very good by use of a surfactant. And for a premature, another handicaps. We always say, what are the prematurity handicaps regarding your lung, regarding your heart, regarding your kidney? Because premature is not similar to your term baby. So high chest for compliance and airway collapse very easily. So these are the things you know. During the course of RDs, FRC star. When you treat your P value will initially increase, then it will decrease. Your AADO2, which was initially on the low side, will start improving, and your similarly PIP will start decreasing. Initially, you started on a higher P, you know, giving a P of a PIP of it more of 20, 25. This is why we are using P for FRC. Why we are using PIP for improving compliance. Similarly, your AADO2 and FAO will start decreasing when you have given surfactant or PIP and resistance and respiratory system. All the things will get settled down after you have provided your treatment either by surfactant, either by ventilation. If you are not going to make complication please. So RDS, we are ventilating a baby, you know, compliance decrease. So resistance is more or less normal after LDB. So your typical settings are LDB of 50 to 60. Your inspiratory time constant is because for this time constant is basically what it is because of compliance into resistance. Your compliance is already decreased. So your inspiratory time constant will decrease. Then you can keep it around the area of 0.35, expiratory automatically does 0.65, AD will already increased. So you have to keep initial by 40 to 50%, whereas RC is already increased. So we to optimize the lung volume, you have to keep it around 5 to 6 and work for breathing is increased. So increase the respiratory rate of 50. So now you have understood why what kind of ventilation settings we have to use, what parameters, what numbers we have to use. This is not a rule that 15 has to be given, 16 has to be given, but the basic things you need to remember about all these things. Resistance, compliance, expiratory time, constant, all these things. So this part I already done. So important is that now weaning. This is important. You have put a RDS baby and given all the therapies. Remember, prerequisites includes your clinically and hemodynamically stable baby. Effective respiratory efforts have started to come. Basic lung pathology is no significant comorbidity there, and your blood gases are optimal if you are having a breathing. Then, if you are a chronic ventilated baby, all the above features of acute ventilation baby should be there. And for chronic baby, remember, these are only weight gain which can prevent a baby from dying. If you are getting a BPD, you will say, I am using this, that. It will never help. Weight gain is a thing which will keep your baby alive and will treat a baby for course of time. Your serum electrolytes in a chronic ventilated baby should be normal. And hematocrit is very important. You have to keep chasing your hematocrit. You should not keep a baby away from a normal hematocrit. So this is a very good slide taken from STD guidelines. These are approach to respiratory term you want. If you have not understood anything till now, just grab this slide. You will understand something. So respiratory distress, you are having a baby, you have to assess a severity. I have already told Downey score and your Silverman score, A ratio, AD, open oxygenation. Then you have to label mild, moderate, severe, and poor respiratory effort. This is the thing where your CPAP man will fail. Then you have a supportive care, which is a basics of neonatology. And then you can choose your armamentarium process. Your nasal cannula, avoid this because it is a dry air which is coming, which is very cold. Your HFNC or triple HFNC, which we say, HFNC, it should be used in mild, moderate RT. You can use H3FNC, the CPAP. Severe RTs, you can try CPAP till rule of 7. Stretch 7 centimeters of the water, 70 and 5 2. So you can give up. Then you maybe on it. Maybe not if all these things are basic. Go for it. Ventilation. And these are having suffocated 20 kilograms. That's what I did. It's very difficult to understand. So this is a very good infographics from my friend. So look at this. A baby. Your machines, your armamentariums affected, your antibiotics least good for your RDS except for your pneumonia patient. Even if OI has increased 40, you go your pulmonary vasodilatory if you are dealing with a complicated kind of your RDS. And in particular, it is like HFO and your non. Here, your respiratory support transition from your oxygen, high phase, so we have understood how we have to transit. We have to start with low flow oxygen, then go to high flow devices, then go to CPAP, then go to NIV, and then move to this invasive respiratory support. This all we can do for a baby who is having a severe RDS, we can categorize as per the previous. Now we will move to pre-term unit. This is for a term unit. You can have a suffected deficiency 10% cases or a child, which we say interstitial lung disease in a newborn. So this is a very good flow diagram. So your 34 weeks important is your delivery room.
Here comes the role of delivery to CPAP, which we say like we have to be with a nasal CPAP or a delivery to CPAP or TEP resuscitator, which is commonly used in a good NICU level 3 NICU. Because you have to keep the alveoli open, do not let the alveoli collapse to increase the FRP. And then these are the guidelines how to start any PPP. If it is failing, if your knee airway pressure is more than 7, increasing, and then move to your aggressive ventilation. Similar to your ventilation. But here, that sepsis should be taken care of. India, we are full with sepsis. You are simply saying we are not using a respiratory kind of antibiotics in our NICU, and we are giving very nicely with our babies. But remember, keep on a high threshold to look for sepsis and freedom. So this is freedom. With this good former from a delivery group with English neobuff or TB indicator, because if this time golden rule is being broken, then you will find very difficult in treating these RDS cases. Then you have a NIPTV, you have BiPAP, you have CPAP, BiPAP. I will never use just in ventilator settings. We have a ABRB mode where we can also. So supporting care, again, your surfactant very important. You need to remember surfactant when to give a surfactant in a preterm baby. Rule of 5 is not applicable to a baby who was just born and you have started a CPAP. The rule is different for a baby with a preterm unit. That was for a baby who was deteriorated or gained during researches or any kind of respiratory distress. Then you will move to industrial respiratory support, HFO or in water. So when to call a neonatologist for a respiratory, because most of the pediatricians are dealing with all these things. There are some specific where you can share your problem with the neonatologist. If it is baby, you have put on a ventilator, is not stabilizing, and you need to move to a higher type of ventilation, the HFO or your ECMO support. You are suspecting a cardiac disease, but you are not able to detect that. Fever with only aspiration syndrome, pulmonary hemorrhage, pneumothorax, pneumomediastinum, where the time is a life. You need to remember that you cannot waste your time with a air leaks and all those pulmonary hemorrhage. Even you need to use a factor 7 for that, where the pediatrician role is less. So something about RDAs, these are the recent updates given in 2022, when to use a surfactant in a preterm. In a term, it is only 10%, which are not very common. But that you should know that these are comparison of the latest guidelines which are being now in literature review. Your European consensus guidelines just came in 2022, American, Canadian, and NNF. We have to compare two very important because we are taking India with NNF and European consensus guidelines. Canada thinks something different from European and so delivery room. When to start is CPAP. You have to start CPAP in all less than 30 weeks gestation age and 6 centimeters. Remember, whenever you are dealing with a 30 weeks as a baby, start CPAP at a 6 and India also say same 5 centimeters problem. Or in this is a modification to 2019 guidelines where they are not supporting NIPT. They are saying stick to a CPAP. Now they are moving from a phantom of it. So prophylactic surfactant, no, never use. Even babies, you just say chota tha, you can use. So if intubated, if it is a result medication. Rescue, yes, early rescue is applicable to all the guidelines. Similarly, this surfactant, I told you that these guidelines, but these European consensus guidelines were being funded by this protected alpha, so they are similarly distributed. Protected alpha goes up to 200 milligram, and NNF also supports the use of it. Then this is important. When you have to give this surfactants. The CPAP of the 6 centimeter, your FI2 is more than 30% on your CPAP. Don't wait, give CPAP less than 2 hours. Your things are harder. And in another guidelines, they say less than 34 weeks to maintain SpO2 of a more than 91%. More or less similar to this. And intubated or not, you have to give, ensure all of this know. And nowadays we are using lethal or minimal invasive technique, least invasive. So we don't put any kind of any kind of injury or any kind of pressure they go to learn. So we prefer to use a leader technique by application of the CPAP over there and continue we use affected in a one body. Can we give a second dose of FMT? Yes. And even third dose can be given. And for example, alpha can be given within 2 hours, and third dose need to be given after 12 hours. You are not getting your babies bursting, even you are affected high doses of high settings are being in a ventilator. What to do? You cannot wait baby to die. You have to give a separate because the pathophysiology of the RDS is about your separate deficiency. In mass, separate European guidelines says your NMF guidelines say yes, mass in respiratory terms and term if your oxygenation index is more than 50. So it is not about your baby who is a preterm, he is a better only, your term can be the seeker and the oxygenation index of more than 50. Pulmonary हमने European guidelines say pneumonia is serious. So remember, even studies are being done and literature is in progress, but if you have to believe the census guidelines and you have to believe the literature, you can give with no harm. That's not important. The importance of a focus, as most of my friends, because Dr. Suji has already told about your focus, echocardiography and all those things, for the diagnosis of shock and all the things. But here the role is very important in RDS. Because to RDS, most of the centers still say pneumonia, collapse or a hypersen. Sir, it looks like thymus don't get affected and all those. You need a probe, just put it over the right area with a good expertise. You can have without any kind of assistance from your paramedical staff or any other person who has to come right from downstairs to take X-ray machine and all those things. All these hazards can be done. And beautifully you can differentiate RDS, TTM, your pneumothorax. Pneumothorax, you need a transcrimination test. If you have a machine, just put over there, you will see a lung point, which is classically one is not rising over there, another is moving simple, just put a needle and they will see. Similarly, your TTM double lung point sign, these are classical signs which you can learn in any kind of a class if you want, but here just to make your price of a focus now, it is very important nowadays for RDS. You have pleura, thickened, some kind of a subpleural consolidation over there, and whole of the B lines covered, and you just say it is a RDS. No need of X-ray, no need of any kind of things. And it is very important and very versatile technology available. So simplify summary of my talk. RDS, your clinical factors are prematurity, chest X-ray, ground glass appearance. Let it be there. Your TTN, short labor, your cesarean section, fluid in the fissures, your perihydral congestion is there, simply TTN is there. Meconium in the amniotic fluid, chest X-rays, of catalytic feedback is a meconium association. Pneumonia, either PPA maybe of early onset sepsis or of a long stay in NICU, you will find some kind of infiltrate or a healthy lungs or kind of a consolidation. Your pneumothorax, your clinical factors like sudden deterioration, baby was on ventilator or any kind of a this PPV, then you will get X-ray, read there in the pneumothorax, and to differentiate from the CCSD, your clinical factors like heart murmur will be there, your persistent hypoxemia despite your oxygen, and chest X-ray shows hyperperfusion lungs appear darker, chest X-ray is often normal. So this summarizes my talk and references the article from. Thank you.
The Congress called for non-basic ventilation. The form of the day, try to as far as from the audience.
Any iota of it out, you can ask PGs.
So no questions.
Thank you. Thank you.
Thank you, sir. Now I would request our chief guest, chairpersons to kindly felicitate the speaker.
And to answer Dr. Subhas's question regarding the use of the neuroprotective agents, we are using a melatonin as a regular course in SMG's hospital, but we are not getting any kind of biomarkers to know the effect. But we have seen that the mortality has decreased for severe HI patients. Neurodevelopmental outcomes still not known, but we will publish any kind of a paper from that.
I would also request Dr. Pooja Kaute to please felicitate the chairpersons. Thank you, ma'am. Now for the next session, I would like to call Dr. Mohammad Raza, Professor GMC Jammu, Dr. Keval Samotra, Senior Pediatrician Jammu, Dr. Sheetal Banju, Consultant Pediatrician, AIMS Jammu, Dr. Lieutenant Colonel Vishal Puri, Consultant Pediatrician. Thank you, Chair. Before we begin with the next session, I would like to inform everyone that the tea is being served outside, but due to the club rules, we could not get it inside. So if anybody wish to, can go outside and have it. Until then, we will keep continuing our session. Now I invite young and dynamic Dr. Surjit Kumar, Consultant GMC Jammu, to brief us on the topic Approach to Hypoxia in the Child and its Management.
Thank you. And good evening all. So the talk of today is
on approach to hypoxia in a child who is presenting with pediatric necessity and its management. The objectives of today's talk are what are the causes and mechanisms of hypoxemia, the case-based approach to hypoxemia and management of a child with hypoxemia. So before going to the case-based approach, I would like to start with the basic physiology and mechanism of hypoxia. So we all know that respiratory failure is a syndrome of ineffective gas exchange, and it is composed of ineffective oxygenation, where there is a defect in the transfer of oxygen from air into the blood, and the other reason is ineffective ventilation, where there is a problem in the removal of CO2 from the blood. So we all know that the respiratory failure is two types. Type 1 is hypoxic respiratory failure, which is defined as CO2 which is less than 60 and SpO2 less than 90. Type 2 respiratory failure is also known as hypercarbonic respiratory failure, where the CO2 is more than 50 with a pH of less than 7.35, and if it is more chronic, the CO2 will be more than 20 mercury from the baseline. So it is very important to understand the two terms, that is hypoxia, which is a failure in the oxygenation at tissue level, and that is second is hypoxemia, which is low arterial oxygen tension in the blood. Hypoxemia is caused by various reasons. The most common types are hypoxemic hypoxia, circulatory hypoxia, anemic hypoxia, and introductory hypoxia. So my main focus of talk will be on hypoxic hypoxia. Before going into the further details, I would like to all of you to keep this diagram in your mind, because all of the presentation will be based on this diagram. So respiratory, it is being controlled by the center which is located in the medulla, and then the medulla stimulates the various nerves that are peripheral nerves, and which cause contraction of respiratory muscles. And then when a person breathes in, there is negative intrathoracic pressure. Air moves from oral gap from the trachea into the alveoli, and this is the conducting airways, and when the air goes into the alveoli, this is the respiratory membrane, and then there is a diffusion of oxygen from the alveoli into the circulation. So any problem in first three components will lead to ventilation failure, that is hypercapnic respiratory failure, and any problem in the last two will lead to hypoxic failure, that is hypoxic respiratory failure. So whenever there is ventilation failure, we all know there will be increase in the CO2, and as per alveolar gas equation, which I will be discussing later, there will be decrease in your alveolar oxygen, which will lead to hypoxemic respiratory failure. So it is very important to know with a few formulas. This is your partial pressure of oxygen in the blood. It is dependent on alveolar PO2 and alveolar to arterial gradient. So this is alveolar gas equation. This PaO2 is the alveolar gas equation. It is dependent on FiO2, which is your patient is getting, and on atmospheric pressure and partial pressure of water, PCO2, and respiratory quotient. So if the atmospheric pressure is low, if the FiO2 is low, there will be hypoxia. If the atmospheric pressure is low, there will be hypoxia. If there is increase in CO2, which will lead to hypoventilation, we all know there is decrease in your PaO2. So as a result of which patient will develop hypoxia. Coming to alveolar gradient, it is dependent on respiratory membrane. So any problem with this will lead to hypoxia, and the pathologies which are operating which cause increase in with this gradient are dead space ventilation, shunt fraction, and diffusion limitation. So how do we approach to child with hypoxia? It is very important to know that it means clinical presentation, acuity of presentation, and probability, and then documenting the severity of the disease by doing saturation, monitoring saturation, and doing blood gas analysis and radiology. So any child who is presenting to you with hypoxia, you are supposed to calculate this. That is alveolar to arterial partial pressure of oxygen gradient, which I have already told is dependent on your alveolar gas equation minus partial pressure of oxygen in the blood. The normal value is 5 to 10. So any child who is having this gradient more than 10, likely reason is VQ mismatch. If it is less than 10, the reason is either hypoventilation or low ambient FiO2. VQ mismatch, we all know
Not a physiology knowledge, if it is more than one, it is dead space ventilation. If it is more than, if it is less than one, it is shunt fraction. And shunt fraction in any child who is having physiology of shunt fraction, they will not respond to oxygen supplementation. Whereas children with dead space ventilation, if you provide supplemental oxygen without pressure also, they will respond to oxygen. And this the last one is division limitation. This is the least common physiology of pediatric. We should not focus on this. So next is case with discussion. So we have a child who is around 12 years old who has presented with certain onset of vomiting and pain abdomen, and then he developed inability to sit, and there was generalized weakness. And when the child presented to trial on examination, because the pinpointed, child had bradycarditis and child was having hypoventilation. The rates are less than what should be for his age. So rest of the examination was unremarkable except for in this CNS examination there was hypotonia. So we know what is the diagnosis. This is snake bite. This is a case of snake bite. Typical case of neurotoxic snake bite. So in investigation we did a blood gas. There was hypercapnia, and child was started on nasal form oxygen. Saturation improved to 96%. Half an hour later, the rates become 8 and saturation dropped to 80. The child was intubated and put on NPR. Coming to how to approach this child, looking at the alveolar gas equation, I know child was on room air, he was getting effort of 21%. The partial atmospheric pressure is 760, pressure for water is 47, and the CO2 was 80. So this child is having a PaO2, that is alveolar O2, which is 50. So as a result of which the gap is only 14 because in 30 PO2 was 45 only. So it is a physiology where your gradient is less than 10. So if you remember the diagram, if the gradient is less than 10 or if it is normal, the likely reason is hypoventilation. Okay. So in this case, the physiology of gradient is hypoventilation. So after starting him on nasal form oxygen, please note this point. While referring such a child from periphery, sometimes we refer them without oxygen. So what happens? CO2 is getting retained and your PaO2 is decreasing. Child might come because of hypoxia on the way. If you don't have any facilities, if you are not equipped with advanced airway technique, in that case you are supposed to refer him on nasal form oxygen at least, because once we start him on nasal form, the effort is 40%. And if you can see, the PaO2 is 185. So your child will not have hypoxia. Okay, so it is very important. While referring the child with neuromuscular weakness, to start him on nasal form before referral, you cannot integrate. So in this case, the problem is with the peripheral nervous system. So there is ventilation failure, which is leading to hypoxia because of increase in the CO2. So hypoventilation, what are the causes? Causes are if there is an abnormal central control of respiration, like in patients with meningitis, encephalitis, or if there is neuromuscular weakness in form of GBS, myasthenia, or snake bite. Coming to case number 2, we had a child who was around 3 years old with a known case of nephrotic. Suddenly presenting to pediatric emergency with sudden onset of respiratory distress, and in emergency, child was hypoxic. And respiratory examination was unremarkable, cardiovascular examination was unremarkable, child had only tachycardia and tachypnea. So in this X-ray, we can see on the left side there is polygynia, and blood gas was done which showed hypoxemia with a saturation of 84%. How do we approach this child? So this child has tissue mismatch. So he was started on nasal form oxygen. Initially, child was hypoxic, his saturation was around 84. Starting him on nasal form, the saturation has reached 90%. But is the likely physiology operating now? It is likely to be tissue mismatch. Okay, because if the physiology is shunt, your saturation will not have improved with simple oxygen supplementation. So, CT angio was done, it showed pulmonary embolism and child underwent pulmonary embolism following CT.
So in this case, the problem is with the pulmonary circulation. Coming to next case, 2-month-old child who presented with history of URTI in the illness followed by LRTI, and on examination there was evidence of intrathoracic smaller area obstruction. So this child has the case of prototype case of acute bronchiolitis. In bronchiolitis, we all know what is the physiology which operates in bronchiolitis. It is a problem of airway. So because of increase in the production of airways, there is some airways are obstructed, as a result of which some airways will be infected, and because of one ventilation, some airways will be hyperventilated. So in this case, both dead space ventilation as well as shunt ventilation. This is actually, you can see there is right upper lobe flap, some hyperactive exit is there, and overall lungs are hyperventilated. How do we approach? In the blood gas, child had CO2 which is around 90 and saturation is around 88%. So he was started on as a considered effect of 40%. His CO2 improved and his saturation also improved. So if you look at the problem in this case, this child had a problem of conducting airways and also a problem of pulmonary circulation. How? Because of hyperinflation, there is increase in the pulmonary vascular resistance because your hyperinflated alveoli are compressing your pulmonary vascularity. As a result of it, this child is having, if you look at the lung volume pulmonary vasculature curve, this child is having both shunt infection, which is increased because of pancreatitis, and because of hyperinflation, there is hypertension. Because the lung volume is increased, as a result of which your PVR is low. What are the causes for dead space ventilation? Over-distension, as we see in cases with bronchiolitis, asthma, and during ventilation, if you're giving higher peaks or higher pressures, and in cases where there is a reduced pulmonary blood flow, like in a state of shock or in pulmonary embolism, and in cases where there is destruction of alveolo-capillary interfaces, like we see in emphysema adults. Also, if you give higher FiO2s in such cases, normal mechanism is whenever there is hypoxia, in systemic circulation there is vasodilatation, but reverse happens in pulmonary circulation. In pulmonary circulation, if you are giving higher FiO2, this vasodilatation is actually a compensating mechanism to divert the blood to the ventilated alveoli. If you are giving higher FiO2, your blood will go into unventilated alveoli. So your hypoxic is not to give
वो इधर
higher
रहता है।
FiO2 to the child bronchiolitis.
मैं आपके साथ बैठती हूँ।
Coming to case 4, this child is a 6-month-old child who presented with history of fever followed by fast breathing and
मेरे को बेलो बंद वाला काम कर दिया। मैं को निरोध करने भेजा।
So in X-ray also you can see there is homogeneous of crystal bilateral.
हम बैठ इजी बैठे हुए हैं लोग नहीं यूज
Blood gas showed
मैं बैठ थोड़ी देर बारी बारी के स्लो किया हो गया ना
after starting on nasal form oxygen.
अभी मेरे को बिठाओ फिर थोड़ी देर बाद मेरे को
He was started on nasal form oxygen. His saturation is 88%. So this child has not responded to your oxygen supplementation, simple oxygen supplementation. It tells you that there is a component of increased shunt fraction. This is commonly pneumonia and ARDS. So after he was started on nasal form CPAP, we all know it causes recruitment of alveoli by providing expiratory pressure. So following that, there is improvement in your saturation. So initially he was given nasal form oxygen, and you can see your PO2 is 230, but it is not improving your saturation because there is no diffusion of oxygen from alveoli into the blood because of shunt physiology. Once you have given CPAP, that shunt physiology is overcome, and that is the challenging response after starting on CPAP. So in this case, the problem is with the respiratory compression. We all know in shunt fraction, the VQ mismatch, and the VQ ratio is less than 1, and there will be decrease in the saturation. PCO2 may be normal or high depending upon the degree of shunt. Once we provide positive
ventilation, there is decrease in the interposition tank because improvement of the
मैं सभी की तरफ से पूछ रहा हूँ
So coming to another case,
किसी ने
who presented with increased with duration of sleep during crying and sudden unconsciousness following persistent crying. This child had central cyanosis in grade 3 clubbing and examination there was systolic. So it tells you that there is a physiology which is like of physiology. On investigation, the child was hypoxic, his stroke was only 40 and he was started on nasal pump oxygen but there was no response to nasal pump, simple nasal pump oxygen, so it is likely to be a shunt physiology. What is shunt physiology? There is perfusion, but there is no ventilation. Means your unoxygenated blood, deoxygenated blood is getting is going from right to left. Okay. So in shunt, the physiological shunt rate is normal, so around 2 to 3%. Pathological can be intrapersonal, can have cold, in cases which are case of pneumonia, and in cardiac, like in Doppler, physiology is where there is higher right-sided pressure. So it is very important to know what degree of what is the severity of shunt which is operating. Any child who is having pneumonia but responding to oxygen, it means the shunt physiology, the shunt pressure is less than 30%. And in child who is having refractory hypoxemia to FiO2, you are giving 100% FiO2, but child is not improving, it means the shunt pressure is more than 50%.
मैं पूरा साथ दूंगा आपको बट थोड़ी हेल्प आपको चाहिए
Another child who is a resident of Calcutta presented to a health center at Lake. He was playing and suddenly started complaining of chest pain. In examination, it was unremarkable except for tachypnea. X-ray was normal. Blood gas showed PO2 which was low. What it tells you? It tells you that the partial pressure of the pressure, atmospheric pressure at higher altitude is low. As you ascend, your atmospheric pressure decreases. Okay. If you go to the alveolar gas equation, this is the alveolar gas equation. Normally, the normal pressure is 760. Here it is 607. You can see the PO, that is RT, alveolar partial pressure of oxygen is decreased. So this child has low partial pressure of oxygen in the alveoli because of low ambient pressure. Okay. So in this case, the reason is this. It is not because of V2 mismatch, not because of diffusion effect. So your alveolar gradient is maintained. It is 10. It is not more than 10. There are conditions where your alveoli gradient will be high. These conditions are conditions where your V2 mismatch is operating. If the V2 your gradient is less than 10, there are only two situations. One is hyperventilation. Second is low ambient pressure or low FiO2 in that muscle. This is the summary of the presentation. Thank you.
You are a latest verification chairman on the crown of the uprising pediatric department. Good efforts carried by Dr. Stanley, previously calculated by OC. Very nice presentation, very informative, particularly in the case with the accident. Any question or queries or any other realists, any of the these doctors? Most welcome. It seems very graceful here. Having heard the, I'll take liberty of 1 minute, having heard the four axes, I'll go with the short message, not long message. Hypoxia, asphyxia, shock, and then RDS. RDS prompt hyperdynamic management on the part of the doctor available or under any circumstances, baseline to the solution. There is a message which should go that earliest oxygen level is restored within minutes. Better it is for the future of the field. And follow up at 1.5 months. Endoscopy, echocardiography, and if possible, scan of the brain. We'll go a long way after the pediatricians and doctors to give a healthy baby in future also. Before we go with the management or the parameters of the camp. This start coming after 1.5 months, 3 months later. These things I feel personally. Maybe some people might have better idea. But this is my feeling. Very nice presentation and we thank you for the.
Any other doubt, I would like to put emphasis on choose your oxygen delivery device wisely. First, check what is the physiology is operating in that particular child and then decide your delivery device. Don't do anything major because a child with pneumonia will not respond with hypothermia, will not respond with HFNC, he will respond to CPAP. Child with DQ mismatch, don't go straight away into it. The child with hypoventilation, do not wait for him to get the hypoxia. So always choose your device, oxygen delivery device, depending upon the physiology which is operating that child. Thank you.
Thank you, sir. We thoroughly enjoyed every minute of your lecture. Now I request our chairpersons to kindly felicitate the speaker. I would also like to call Dr. Priyanka Sharma to kindly come up on the stage and felicitate our chairpersons. Thank you, ma'am. Let us now take a moment to remember Dr. Ritu Gupta, wife of Dr. Ravinder K. Gupta, who is one of the organizing chairpersons of today's event. Her spirit of enthusiastic participation in her zealous sense of learning is missed by one and all, every day and especially today. As rightly said by Abraham Lincoln, in the end, it's not the years in your life that count, it's the life in your years. She proved this by living her life in the most loving and caring way and gave us a lifetime of memories. Dr. Ritu did her MBBS in 1987 from GMC Jammu. She completed her internship in 1993 and did house jobs in 1994. She got a PG. She got a PG diploma in pathology in 1997. Because of her passion for teaching, she opted for MD in physiology, though she was eligible for many of the clinical subjects. After completing her post-graduation, she served in a difficult rural posting, Bentan, a border area in Samba district, which witnessed on and off cross-border skirmishes, yet selflessly served in extreme conditions for 6 months. She joined as a demonstrator in 2001. She was selected as a lecturer by PSC in 2004 in the physiology department and became professor in 2020. Teacher for both undergraduates and postgraduates. She had almost 40 publications in the national and international journals, authored many chapters in textbooks as well as recent advances, and also undertook many research projects. She was a guide to many postgraduate students, examiner of undergraduates as well as postgraduate at various universities, attend many national as well as international conferences, and presented scientific papers. Dr. Ritu Gupta used to attend all the pediatric conferences, be it local, regional, zonal, national, as well as international, along with her husband. She had a special interest in academic, especially in the children's physiology. Keeping this in the mind, the organizing committee of update on neonatal and pediatric emergencies has decided to keep a scientific program that is Dr. Ritu Gupta Orations on her name to keep her alive. Thank you. I would request our chairpersons, Dr. Ashok Gupta, ex-professor and HOD Pediatrics SMGS Jammu, Dr. G.S. Saini, professor in HOD SMGS Hospital and president of IAP JNK and organizing chairperson for today's event, Dr. Ravinder Gupta, professor and HOD ASCOMS Hospital Jammu and president IAP JNK and organizing chairperson for today's event, Dr. Sanjeev Dhingra, professor pediatrics and convener scientific committee, to kindly come on the stage. I would like to invite our distinguished guest from PGI Chandigarh, Dr. Jayashree, who is heading the Pediatric Intensive Care Unit, shall be presenting her views on the topic pediatric shock and its management virtually. She was on the way, but due to bad weather and torrential rains at Chandigarh, she couldn't make it. So she'll be presenting virtually.
Hello, am I audible? Hello. Audible? Okay, okay. Just check once if my screen is visible, Surjit. screen visible? Hello? Am I audible? Hello? Yes, I can hear you. I am not able to change the slides. Hello?
Yes, ma'am.
Audible?
Yes, ma'am. Yes, ma'am.
Okay. Just see if the slides are scrolling. Is it there?
No, I'm not.
Now?
Not. मैम एक्चुअली आप एक बार एग्जिट करके देना
हाँ, फिर वो आए।
exit the meeting.
मैम फोन आ रहा है, फोन आ रहा था अभी भी।
Is it visible now?
Yes, ma'am.
Okay. Is it scrolling?
Yes, yes.
Okay. And I'm audible also? Okay. Right.
Very well.
Okay. Thank you. Good evening, everyone. Thank you very much for this invite. And my apologies that I could not join you physically. Some of the rain has played spoil sport and I couldn't reach Jammu because of the flooding that was there in Chandigarh, Mohali and other places. I'm going to speak in the next 20 minutes about recognition and management of shock in children. My talk is basically geared towards pediatricians who might first see these kids in their OPD or in their hospitals, and then do the first golden hour management and then refer to tertiary care center. So I would talk briefly about the importance of recognizing shock in golden hour and what are the components. We all know that fluids are an important part of shock therapy. So what are the important considerations, especially with fluid therapy in septic shock? The role for early vasoactive therapy, because there is a lot of discussion whether it should be dopamine or epinephrine, which one to start. We often talk about distinctions like warm and cold shock, but this is a very oversimplified classification. And recent evidence tells us that we should not be probably looking at shock only as warm and cold shock. Antibiotics are a very important component of septic shock. So how do we time it? Of course, some important adjuvant therapies like should we use steroids or not? What is dose control and how important it is? So we all know that sepsis basically is a dysregulated host response. There is infection, but how the host reacts to this particular infective pathogen is what determines the whole organ dysfunction that is in sepsis. And as you can see in this particular slide, that the child first will come with simple sepsis, then will go on to severe sepsis, and then will go on to septic shock, and finally multi-organ dysfunction. And as the stage progresses, the mortality also increases. Therefore, for all of us who take care of children, especially with sepsis and septic shock, time is very important. It is very crucial because the whole outcome depends on the timely recognition and management of septic shock. So therefore, this very interesting concept, what is called as golden hour, it not only applies for septic shock, but it applies for all emergencies, whether it's adult or pediatrics. So these are the first hours following the diagnosis of severe sepsis and septic shock. And if we manage the child in this window, we are assured of improved survival rates and reduced organ dysfunction. So therefore, it is important for all of us as pediatricians. It's not only the job of intensivist or emergency physicians, but all pediatricians to recognize children within this golden hour. This concept of golden hour basically came from the golden hour of photography. It is a period of daytime shortly before the sunrise or before the sunset. So it's a very narrow window. And that's why in emergencies, it is very important that we recognize the golden hour. So if we to summarize the principles of management of shock, there are certain important goals or concepts that we need to remember. One is that we have to increase the oxygen content of blood because you all know that shock is nothing but a mismatch between what the tissues demand and what the heart is able to deliver. Improve the volume and distribution of cardiac output because this is the main problem in shock. Reduce the oxygen demand. We want the oxygen to reach the vital organs. Therefore, the other organs which keep demanding oxygen, we need to put them to rest. So therefore, we need to reduce oxygen demand. The simple example is you support the child's ventilation or give oxygen so that the respiratory muscles are able to rest. Correct metabolic disturbances. And most importantly, once you have stabilized the first four, we need to identify and treat the underlying cause of shock. Is it simply hypovolemia? Is it because of some cardiac element or is there a septic shock? So we need to look at what has actually triggered the shock. We always need to remember that there are certain therapeutic targets that we need to. Whenever we do interventions in sick children, it's important for us to keep in mind some of the targets. So those targets therapeutic targets can be divided into groups that is macrocirculatory as well as microcirculatory. What do you mean by this distinction is macrocirculatory means all the hemodynamic parameters that you can measure at bedside. It includes the skin temperature and circulation, the capillary time, the quality of the central and peripheral pulses, the systolic blood pressure, as you are giving fluids and vasoactives, and whether the urine output has been established to more than or equal to 1 ml per kg per hour. On the other hand, the microcirculatory, that means when the oxygen reaches the tissues, how the tissues are using this oxygen. This is something that we can't measure at bedside. We need to do certain tests. So the most important surrogate for knowing whether the microcirculation is adequate or not is to look at the serum lactate and to look at the lengths of lactate so that initially the lactate is high, whether the lactate is increasing with your intervention. And another variable, what we call as the mixed venous oxygen saturation, this should be more than 70. But an important point that all of us need to remember is that if the macro circulation looks reasonably okay, it doesn't necessarily mean that the micro circulation is also going to be absolutely okay for the child. So often these two parameters may not go hand in hand.